Welcome to the deep dive. If you look at the current American Urological Association guidelines, um, placing an artificial urinary sphincter in a female patient is not even FDA approved.
Right. It's basically treated as an experimental ghost in the United States.
Exactly. But then, if you cross the Atlantic and look at the national guidelines in France, for example, that exact same device is celebrated as the absolute gold standard for treating complex incontinence.
It's wild, yeah.
You rarely see such a massive transatlantic divide over a piece of hardware that has existed for 50 years.
The contrast is honestly staggering. And, for anyone listening today who follows medical technology or urology, you are about to see how a device's success isn't just about whether the mechanism works.
Right.
It is heavily dependent on how the surrounding technology, like specifically the surgical approach, has to evolve to make the invention viable.
Yeah, it's a story of abandoned techniques, heavily debated international guidelines, and how modern robotic surgery is rescuing this brilliantly designed, life-changing treatment.
It really is. It's a masterclass in how medical innovation is just not a straight line.
Definitely. So our mission today is to unpack the artificial urinary sphincter, or the AUS, specifically for female patients suffering from complex stress urinary incontinence.
Right.
We have a pretty deep stack of source material today, ranging from international surgical outcome studies to historical reviews of the device. And to understand why this device is so polarizing, we should probably start with the specific, physiological failure it's actually designed to fix.
That's a good place to start, yeah.
Because we are bypassing the standard hypermobility cases today, right?
Right.
We're focusing on intrinsic sphincter deficiency, or ISD.
We are, yeah. Because anyone familiar with urogynecology knows that standard urethral hypermobility is, it's a failure of the extrinsic support system.
The hammock, basically.
Exactly. The pelvic floor weakens, and the urethra loses its anatomical backing. But ISD is a completely different beast.
So,
Well, this is a failure of the intrinsic mechanism, like the actual smooth and striated muscle complex of the internal and external sphincters.
I'm trying to visualize the mechanical difference here. If standard hypermobility is a loss of structural support, like a house with a crumbling foundation,
Yeah.
how should you conceptualize ISD?
Think of ISD less like a foundation problem and more like a dry rotted rubber seal on a pressurized sliding door.
Okay, a dry-rotted seal.
Yeah. The door itself might be perfectly aligned on its tracks, well supported by the surrounding frame, but the seal has completely lost its integrity.
Oh, wow.
The urethral tissue in an ISD patient is often rigid, scarred, and fundamentally incapable of coapting.
Coapting meaning like closing properly.
Right, meaning it cannot squeeze tightly together to create a watertight seal. Clinically, you see a fixed, poorly mobile urethra with a dangerously low maximum urethral closure pressure.
Got it. So if the biological seal is completely dry-rotted, the intervention requires replacing the seal entirely. And the sources point to the AMS 800, which is the specific artificial sphincter device. And the crazy thing is, the core engineering of this system hasn't seen a major overhaul since the late 1980s.
Which is practically ancient in medical device years.
Totally ancient. So it's a three-piece hydraulic system, right?
Yes. The elegance really is in that simplicity. So the first component is a fluid-filled cuff placed circumferentially around the bladder neck.
Like a little ring.
Yeah, exactly. The second piece is a pressure-regulating balloon implanted in the lower abdomen, which, serves as the fluid reservoir.
Okay.
And the third is the control pump placed externally in the labia majora. They are all connected by this thin tubing routed under the skin.
Wait, I am stuck on the mechanics of that cuff.
Sure.
If you wrap a fluid-filled ring around the really delicate tissue of the bladder neck and keep it pressurized 24/7 to stop urine from leaking, wouldn't you just slowly choke out the blood supply?
That's a great question.
Like, how does it not cause necrosis and just cut right through the urethra over time?
Well, that is the exact engineering hurdle the inventors had to solve. And it's why that abdominal balloon is so crucial.
Oh, the balloon does that.
Yeah, the balloon isn't just a storage tank. It is precisely calibrated to operate at a pressure of 61 to 70 centimeters of water.
And why that specific number?
Because that specific pressure threshold is high enough to keep the urethral mucosa closed against typical abdominal pressures, but low enough to maintain capillary blood flow to the surrounding tissue.
So it's a very delicate balancing act between continence and tissue perfusion.
Exactly. It's brilliant.
So the system rests in a closed, pressurized state. And then when the patient actually needs to void, She manually squeezes that small pump located in the labia.
Right.
And the physical squeezing actively pumps the hydraulic fluid out of the cuff and pushes it up into the abdominal reservoir.
Yes, so the cuff completely deflates, dropping the resistance in the urethra to basically zero, allowing the bladder to empty normally.
And then what? Does she have to pump it back up?
No, actually, the system utilizes a specialized resistor valve inside the pump.
Oh, nice.
Yeah, over the next 3 to 5 minutes, that valve allows the fluid to slowly, automatically trickle back down from the abdominal balloon into the cuff, repressurizing the system. The patient doesn't have to pump it back up at all.
The fluid dynamics there are just brilliant. It perfectly mimics the biological action of a sphincter, relaxing and then passively regaining tone.
It really does.
But this brings us back to that transatlantic divide we talked about.
Right.
If this device so accurately replaces the biological function, why did the United States essentially abandon it for women while Europe embraced it?
The timeline explains a lot of the geographic disparity here.
Sure.
The original device was actually developed in 1973 by Scott, Bradley, and Tim.
1973.
Yeah. And remember, in the early 1970s, the massive wave of radical prostatectomies that we see today hadn't happened yet.
Oh, true.
So the male incontinence market was actually really small.
Wow.
The inventors initially targeted this technology toward women.
Wait, really? It was for women first?
Yes, mostly for women. But, I mean, designing a brilliant hydraulic system in 1973 is one thing. Actually getting it deep into the female pelvis safely with 1970 surgical techniques is another entirely.
And that was the fatal flaw. In North America, the early surgical pioneers attempted to implant the cuff using a vaginal approach.
Which means?
They would incise the vaginal wall to dissect upward and reach the bladder neck.
Just from a purely anatomical perspective, that sounds incredibly risky.
It was.
The tissue layer between the anterior vaginal wall and the urethra is remarkably thin, and you are operating in an area heavily populated by vaginal flora.
Exactly. And the outcomes reflected those exact risks. Implantation through the vagina led to catastrophic rates of infection.
I can imagine.
Worse, because the vaginal tissue overlying the mechanical cuff was so thin and already compromised by the incision, the cuff would frequently erode straight through the vaginal wall.
Oh, that's horrific.
The morbidity was just unacceptable, and the vaginal approach was widely condemned.
And because of those disastrous early data sets, the US FDA drew a hard line and never granted approval for the device in female patients.
Right, which forced American urologists to look for alternative solutions for ISD.
And the sources show the industry pivoted hard toward the midurethral sling, right?
They did. The synthetic midurethral sling revolutionized the treatment of standard hypermobility.
But not for ISD.
Well, for intrinsic sphincter deficiency, where the tissue is rigid and the seal is broken, surgeons were throwing everything they had at the problem. Beyond synthetic slings, they utilized birch colpo suspensions, autologous fascial slings, and urethral bulking agents.
For those listening who might only be familiar with standard mesh slings, let's break down the mechanics of those alternatives for a second.
Sure.
A birch colpo suspension isn't putting a new material under the urethra, right? The surgeon is actually grabbing the vaginal tissue near the bladder neck and suturing it upward to the Cooper's ligament on the pubic bone.
Exactly. You are creating a biological shelf by suspending the anatomy.
Right. And with an autologous fascial sling, the surgeon harvests a strip of the patient's own tissue, usually from the rectus fascia in the abdomen, and creates a hammock underneath the urethra.
Yes, completely owned tissue. And then bulking agents take a different route entirely.
How so?
By injecting hydrogels or silicone directly into the urethral submucosa to artificially plump up the tissue and force it closed.
Right. But every single one of those alternatives shares a fundamental biomechanical limitation, don't they?
They do.
Whether it's a mesh sling, a suspended biological shelf, or an injected gel, they all rely on creating a static, permanent obstruction, like they compress or elevate the urethra permanently.
Yes. And while those static obstructions work decently well for some patients, they fail at an incredibly high rate for severe ISD.
Which brings us back to Europe.
Exactly. That is why those high-volume specialized surgical centers in Europe, primarily in France, the UK, and Belgium, refused to give up on the artificial urinary sphincter.
Because they knew the dynamic compression of the AUS was physiologically superior to any static sling.
Exactly. But the European surgeons weren't using the disastrous vaginal approach.
Right, what were they doing?
They were doing open abdominal surgery, They made large abdominal incisions, bypassed the vagina entirely, and dissected down into the reticia space to access the bladder neck from above.
But the sources constantly refer to the open abdominal approach as having high morbidity. I want to unpack that clinical term for a moment because it sounds really sterile on paper.
It does.
The female pelvis is essentially a deep, narrow, bony funnel.
Right.
To do this open surgery, a physician is leaning over a patient, trying to work at the very bottom of that dark funnel, navigating a dense venous plexus and delicate organs, using rigid, straight instruments.
It's incredibly difficult. And add to that anatomical challenge the fact that most women receiving an AUS have already failed multiple previous surgeries.
Oh, there's scar tissue.
Tons of it.
Yeah.
The surgeon isn't navigating pristine anatomy. They are hacking through dense sheets of scar tissue and remnants of old synthetic mesh just to find the bladder neck. So high morbidity in this context means a significant risk of massive blood loss, high rates of accidental perforations into the bladder or vagina, long hospital stays, and severe physiological stress on the patient. It was a brutal surgery.
The European experts managed to master it through sheer repetition in specialized centers, but it was practically unteachable to the broader urological community.
It was just too difficult and too risky.
That is the gridlock this device was stuck in for decades.
Until the technology of the operating room finally caught up to the technology of the device.
And to the robots.
Exactly. The past decade has seen a complete paradigm shift with the introduction of robot-assisted laparoscopic implantation.
The robotic renaissance. So instead of looking down into that deep, dark funnel from a large abdominal incision, the robotic approach changes the entire geometry and visibility of the procedure.
It really does. The sources detail the anterior robotic approach, and the mechanical advantages are profound.
What's the setup look like?
The patient is placed in a 23-degree Trendelenburg position, so tilted head down.
To let gravity help.
Exactly. Gravity gently pulls the bowel and intra-abdominal organs out of the pelvis, clearing the workspace.
That makes sense.
Then the surgeon places 5 small trocars, or ports, across the abdomen.
So you completely eliminate the massive open incision.
Completely.
Through those tiny ports, the robotic platform introduces a high-definition 3D camera and instruments that articulate with multiple degrees of freedom.
It's like having miniature illuminated wrists operating at the bottom of the funnel.
I love that analogy. It's like diffusing a bomb, but instead of wearing oven mitts like in the open surgery, you suddenly have superhuman precision.
That's a perfect way to put it. The magnification allows the surgeon to meticulously dissect the bladder neck away from the underlying vaginal wall without injuring either structure.
Which avoids the fistulas and erosion.
Exactly. They can carefully navigate around the old scar tissue with a level of precision that is simply impossible with the naked eye and rigid, open instruments.
I actually found the measurement phase fascinating in the sources.
Oh, yeah.
Once they isolate the bladder neck, they actually insert a sterile, flexible measuring tape through one of the robotic ports to wrap around the tissue.
Yes. Accurate sizing is critical to prevent that tissue necrosis we discussed earlier.
Right.
The robotic instruments allow them to measure the circumference perfectly, which for most female patients dictates a cuff size of around 7 to 8 centimeters.
Okay, 7 to 8 centimeters.
Yeah. They introduce the cuff, lock it into place, and then tunnel the tubing out to the labia and the abdomen to connect the pump and balloon.
And the data on the back end of this robotic shift is phenomenal. Because the tissue handling is so delicate, the complication rates have dropped drastically.
Significantly.
Specifically, the explantation rates,
Yeah.
the nightmare scenario where the device has to be surgically removed because of erosion or infection, have plummeted compared to the open and vaginal approaches.
The robotic approach has democratized the procedure. It is no longer restricted to a handful of European masters. It is driving a global resurgence in the AUS for female patients.
So, assuming a surgeon has the robotic platform and the skills, who is the ideal candidate?
Right.
We've talked about ISD, but practically speaking, who is the index patient that should be exploring this option?
The literature is very clear on patient selection. First, it is women with complex stress incontinence who have exhausted the standard playbook.
Meaning they've had other surgeries.
Yes. If a patient has failed a midurethral sling, a Butch-Culpo suspension, or bulking agents, and they are still suffering from severe leakage, they are a primary candidate.
They've tried the static instructions, and their biological seal is just too degraded.
Exactly. The second major cohort is women with neurogenic stress urinary incontinence.
Okay, neurogenic.
These are patients whose sphincters fail to close due to neurological deficits,
Yeah.
perhaps from a sternal cord injury, spina bifida, multiple sclerosis, or severe pelvic trauma.
For both of those patient groups, the sources highlight a physiological advantage to the AUS that is just incredibly vital for aging patients.
Yes.
And it goes back to that difference between a static obstruction and dynamic function.
This is the crux of why the AUS is superior for the right patient. As we age, or as neurological conditions progress, many patients develop detrusor under activity.
Remind us what the detrusor is.
The detrusor is the smooth muscle of the bladder wall. Over time, it loses its contractility. It simply cannot squeeze hard enough to push urine out.
Right. So if you take a patient with a weak bladder muscle and you install a standard mesh sling to stop their incontinence, you've essentially permanently narrowed their urethra.
You've created a roadblock. A weak bladder cannot generate enough pressure to push fluid past that permanent surgical obstruction.
So they can't pee at all.
Exactly. The patient might be cured of their incontinence, but now they face urinary retention. They might have to self-catheterize just to empty their bladder.
But because the artificial urinary sphincter is dynamic, it actively drops the resistance to zero.
Yes.
When the patient squeezes the pump and deflates the cuff, the pathway is completely wide open. Even a severely weakened detrusor muscle can easily empty the bladder without having to fight against a surgical hammock.
It restores the natural physics of voiding. High resistance during storage, completely low resistance during emptying.
That makes total sense.
Yeah, no other surgical intervention for female incontinence can claim that dynamic capability.
It sounds like a biomedical triumph, but I mean, we have to ground this in the everyday reality of the patient.
We do.
The physical interface of this device is a significant hurdle. Having a hydraulic pump prominently implanted in the labia majora that you have to manually locate and forcefully squeeze every single time you need to empty your bladder is not a minor lifestyle adjustment.
No, it is a massive physical and psychological commitment, and it requires a blunt preoperative conversation.
I'd imagine.
The requirement for manual dexterity is a non-negotiable barrier. Our sources highlight a sobering statistic. Up to 14.9% of women ultimately fail to operate the pump effectively.
Almost 15%. That's high.
It is.
Because if a patient has severe arthritis in their hands, or reduced motor control from Parkinson's, or a previous stroke, operating a small, firm pump hidden beneath the skin might be frustrating at best and entirely impossible at worst.
Absolutely. You also have to consider the long-term reality of harboring mechanical hardware.
Right. Nothing lasts forever.
Implants are not permanent biological fixes. They are machines subjected to the constant stress of bodily movement and fluid pressures. The tubing can kink, the pump can malfunction, and the hydraulic fluid can slowly leak out over a decade.
And even with the precision of robotic surgery, the risk of urethral erosion is never zero.
Right.
The constant mechanical pressure of the cuff, combined with natural tissue thinning as a patient ages, means the device could eventually wear through the urethra.
And when mechanical failure or erosion occurs, the patient faces a complex revision surgery or a complete explantation, plunging them back into severe incontinence.
So it's not a one-and-done deal.
No. It is a highly effective, life-altering solution, but it comes with a lifelong maintenance contract with the healthcare system.
That reality makes me wonder where the engineering goes next. If the core design of the AMS 800 hasn't fundamentally changed since the 80s, what does the next generation of this technology look like?
The future detailed in the research shifts away from closed hydraulic loops and moves toward electromechanical systems.
Oh, interesting.
We are looking at the development of smart sphincters.
Electromechanical, so completely removing the labial pump from the equation.
Exactly. The physical pump is the weakest link, both for mechanical failure and patient usability. The next generation devices will be remotely controlled, likely utilizing a small wireless remote or even a smartphone interface.
Wait, really? You could just tap a button on your phone to open the cuff.
That's the goal.
That entirely solves the dexterity issue for patients with arthritis or neurological impairments.
It does. And beyond the interface, the internal mechanics will be infinitely more sophisticated.
How so?
Instead of relying on a static pressure balloon calibrated to one specific threshold, an electromechanical cuff could utilize microsensors to dynamically adjust its own pressure in real time.
It could sense the body's status.
Exactly.
If you were just lying in bed or sitting quietly, the device could lower the pressure on the urethra to the absolute minimum needed, giving the tissue a break and drastically reducing the risk of erosion.
Right.
But the millisecond you stand up or the sensor detects a sudden spike in abdominal pressure from a cough, it instantly clamps down.
It would be a true bioresponsive implant.
Taking a step back, this entire journey is a testament to the strange, nonlinear path of medical progress.
It really is.
An invention designed in 1973 for women gets abandoned because surgeons were trying to force it through the vaginal wall. It spends decades in exile in the United States, kept alive only by a few stubbornly brilliant open surgery experts in Europe.
Right.
And finally, 50 years later, the invention of robotic laparoscopy unlocks its true potential, offering a dynamic physiological cure for a devastating condition.
The convergence of mechanical engineering and modern surgical robotics has yielded a beautiful solution. But, as we anticipate these upcoming electromechanical, Bluetooth-enabled devices, I think there is a profound psychological question we have to grapple with.
What's that?
Well, we've spent this entire time analyzing the physical mechanics of replacing a sphincter.
The plumbing, basically.
Right, the plumbing. But consider the human experience of that plumbing. As our medical implants become smarter and increasingly digitized, how will our psychological relationship with our own bodies evolve? When one of your most private, basic biological functions, deciding when to empty your bladder, is outsourced to a microchip and operated by an app on your smartphone, how does that change your sense of self?
That's a deep point. Does digitizing our biology make us feel empowered and in control of our failing bodies? Or does it make us feel strangely disconnected, like we are just piloting a machine?
It is a question that every field of medicine will have to answer as we merge closer with our technology.
That is something that will stick with me long after we log off. We started today talking about medical progress not being a straight line. And sometimes, fixing the broken biological seal means installing a highly advanced robotic one and learning to live in harmony with the machine.
Exactly.
Thank you for joining us on this deep dive into the artificial urinary sphincter. We will catch you on the next one.